Okay, good morning. We're going to talk about asymptomatic bacteriuria and urinary tract infection. My name is Ana Velez, one of the attendings at the Infectious Disease Department at University of South Florida. I wanted to show you this picture, and that's in Jericho. Jericho is a little town 4 hours away from Medellin, and it's a coffee town, and it's beautiful. So you see the balconies with colors and everything. Next, what you see here is a young man on your left with a little dog, and then an old guy. What has next to him is a Foley catheter. Reality of life. Hopefully not for any of you in the future. So, when do you screen asymptomatic bacteriuria? Basically, you don't take any UA or urine cultures unless the patient is going for a procedure and some other indications that we'll discuss in the future. And in which you know that by giving antimicrobial therapy, you can prevent complications. So, what is as asymptomatic bacteriuria? Is an isolation of a specific count of bacteria in the urine, usually greater than 100,000, without any symptoms that are attributed to urinary tract infection. And just remember that uncomplicated urinary tract infections in men doesn't exist. But we will be talking about that in a minute. So case 1. A 8-year-old female with history of diabetes is admitted to the hospital because of coronary artery disease. She had an STMI. She had no fevers, no leukocytosis, but she was complaining of foul-smelling urine and very cloudy. So she demanded that they did a UA and urine culture. They did a urine culture, and that was positive for 100,000 colonies of E. coli and 20 WBCs. Based on that, what will you do next? Treat with antibiotic for 3 days with no cultures for follow-up. B, no treatment. C, treatment with antibiotic for 7 days with follow-up cultures, or repeat the urine culture. B, excellent. No treatment is indicated. Treatment with antibiotics for 3 days is really not indicated because she had no urinary tract infection symptoms. You don't. Some people may say repeat the urine culture to verify that the patient really had bacteria in the urine, but if it's not going to change what you're going to do, then you don't need to do it. So no treatment is indicated. Basically, studies have shown that the treatment for symptomatic bacteriuria neither decrease the frequency of symptomatic urinary tract infection or prevent further episodes of asymptomatic bacteriuria. And basically what studies have done, some people say, okay, so if somebody has asymptomatic bacteriuria and some people don't have it, who has more chances of having urinary tract infection down the line? Patients with asymptomatic bacteriuria or patients with no bacteriuria? Logically, patients who have bacteriuria have higher incidence to have urinary tract infection. However, they did studies on patients who have asymptomatic bacteriuria, and one group got antibiotics and the other group did not get antibiotics. Basically, the incidence of recurrent bacteriuria and urinary tract infection didn't really change in both groups, but the patients who got antibiotics have had higher incidence to have multidrug-resistant bacteria because they already had received antibiotics. So that's why, based on this, it is not recommended that you treat asymptomatic bacteriuria. And believe it or not, asymptomatic bacteriuria is really, really common. The prevalence is very common in healthy young women, particularly females that are sexually active, and increases with age, probably because the anatomy changes as you have more kids. You can have bladder prolapse. It's rare in young male, but it increases in males who are older than 60. Why? Because of prostate hypertrophy, abnormalities with the function of the urinary tract, etc. Obviously, disabilities that require Foley catheter increases your incidence to have bacteriuria. And believe it or not, short-term Foley catheter also increases the chances to have asymptomatic bacteriuria. The rate is anywhere from 2 to 7% per day. That's why we insist that if the patient doesn't need the Foley catheter, just remove it as soon as possible. Another picture of the same little town. I'm just showing this to Dr. Eller, who's half Colombian, and there is another Colombian doctor with us, but I'm sure she knows the town. So. Let's do another case. 25-year-old female who's 16 weeks pregnant comes to see you. You say, I'm not an OBG, why are you here? I mean, you go to your OBGYN and she say, well, I'm not sure, I don't really like my OBG, I don't think he has too many patients, he just dedicate me 5 minutes, I need to make sure I have a normal pregnancy and I had many miscarriages before, but she's doing fine, she has no complaints. She wants to have a urine culture. What do you say? A, when she has symptoms. B, only if she has pyuria. C, at the end of her pregnancy. D, now. E, only if she has premature contractions. Who votes for A? Some votes for A. What about B? None. C? None. D? 1, 2 votes for D. E, only if she has premature contractions. Who votes for that one? No. The answer is D, now. So, studies have shown that getting urine culture in the first trimester of pregnancy is better than any time during the pregnancy, and the best time is 16 weeks of pregnancy, with or without symptoms. Why? Because, and you treat, obviously, even if there is no symptoms. Why? Because asymptomatic bacteriuria in early pregnancy has been associated with higher incidence of pyelonephritis, premature birth, and low birth weight. Some may say, oh no, I'm just going to do a UA with and see if the patient has pyuria. If the patient has pyuria, then I send it for urine culture. Well, that has low sensitivity, only 50%. So the best way to go is to get a single urine culture at week 16. Let's do another case. A 60-year-old male comes to have a transurethral rectal prostatectomy. You do a urine culture and it's positive for proteus. The patient has no symptoms of urinary tract infection. Do you treat? Yes or not? Okay. For how long? 3 days before the procedure and 7 days after. Starting the day of the surgery up to 24 hours after. The day before or the day of the surgery, and until the Foley is removed, or none of the above. Nobody? Should I put an option E? No? Oh, I'm sorry, this actually D. So none of the above? All of the above? Actually, the answer is C, the day before surgery or the day of the surgery, and until the Foley is removed. However, if the patient had no Foley right after surgery, then you can stop the antibiotics right after surgery. So why is that? Because patients who have asymptomatic bacteriuria and go for invasive urological procedure that involves mucosal bleeding have up to 60% chances to become bacteremic. And the second point we discussed. So. And this is just to show you how transurethral prostatectomy takes place. And so right here, in your left side, you see the penis, and it's going through the urethra, the needle, and it goes very close to the rectum. So you really are talking about a very invasive procedure, and if you have some bacteria in the urethra, then they'll go directly through there and can reach your bloodstream. So you may say, okay, if a patient has asymptomatic bacteriuria and is going to have a Foley catheter placed, do I need to give prophylactic antibiotics? No. It's only recommended when you're going to do a urological procedure in which mucosal bleeding and trauma is anticipated. Remember that screening for asymptomatic bacteriuria is not recommended for premenopausal, no pregnant women, because of how you're going to see things that you don't want to see or don't know what to do with. You don't want to screen this in diabetic women. Chances are very high that you're going to find something. Older patients living in the community or nursing home, patients with spinal cord injury, so that's very common at the VA, or catheterized patients while the catheter remains in place. Unless obviously the patient has symptoms, then you screen. What about organ transplant? The evidence is not clear whether if you need to screen a solid organ transplant to see if there is presence for asymptomatic bacteriuria or if you need to treat. There is no clear evidence, particularly true in renal transplants. They used to do it the first 6 months after the transplant. Now it's not clear. And the guidelines to screen patients with stem cell transplant to see if they have asymptomatic bacteria is also not addressed or not clear according to the guidelines. Another picture of the little town. I'm giving 2 presentations. Go to Colombia and visit, and then UTI. See, my husband is right there, trying to climb the stairs, out of breath. Okay, so when you do a urinalysis, what do you need to look for? Obviously, in symptomatic patients, you need to look for white blood cells. But remember, patients neutropenic don't have white blood cells, so you cannot say, oh, they don't have urinary tract infection if you don't see pyuria. You also look for red blood cells, epithelial cells, but also remember, if the females have vaginal discharge, you may see a lot of epithelial cells. You look for leukocyte steroids and protein. But also remember that pyuria signifies inflammation in the urinary tract. And there are many causes for inflammation, not just infection. And you may have bacteria and inflammation without necessarily meaning that the two are related. Pyuria and asymptomatic bacteriuria can be seen in up to 32% of young female, 30% to 70% of pregnant women, 70% of diabetic women, 90% in elderly institutionalized patients, 90% on hemodialysis patients. Of course, they have renal problems, so they may have inflammation. 30 to 70% of bacteriuric patients with short-term catheters, and up to 50 to 100% of patients with chronic Foley catheters. So that's, if you treat every time you see pyuria and bacteria, you're going to end up using a lot of antibiotics without the need. There are other causes of pyuria that are outside of urinary tract infection, including renal tuberculosis, sexually transmitted diseases, and of course non-infectious such as interstitial nephritis. Remember, again, by itself, the presence of pyuria is not sufficient to diagnose, not bacteriuria, but urinary tract infection. The presence of or absence of pyuria doesn't differentiate symptomatic from asymptomatic urinary tract infection. We treat patients, we evaluate patients, we don't treat labs. And unfortunately, how the medicine is going now, you have to see many patients in a short period of time, and you ended up just looking at the labs and everything, and you don't talk with the patient, you don't check them. Who knows if you are sent to see a patient with asymptomatic bacteriuria and pyuria, and if you don't talk to, let's say it's an old lady that happened to me in the clinic, 80-something year old, they sent it to me for recurrent urinary tract infection. She didn't have no symptoms, but when I look and when I asked her, she had a lot of incontinence and she had severe bladder prolapse. So if you don't look, if you don't ask, she'll be on antibiotics forever, and the poor lady will still be suffering from this prolapse. So another picture of the town. This is a house, a typical house. So we talk about asymptomatic bacteriuria and pyuria, and when you screen and when you treat basically pregnant women and patients who are going to have an invasive procedure. Now let's talk about uncomplicated urinary tract infection. It's basically a symptomatic bladder infection that is characterized by urinary frequency, dysuria, suprapubic pain, and it is usually, when it's uncomplicated, is usually in females who have normal genitourinary tract. Complicated urinary tract infection can also involve the bladder, just the bladder, not necessarily has to be always pyelonephritis. It could be the bladder. The difference is that these patients can have functional or anatomical problems. So the treatment may be different, even if it's cystitis. One thing is to treat cystitis in a healthy woman versus cystitis in a patient who has folate, who has different anatomical problems, stents, etc. And remember that urinary tract infection in men, even if it's just cystitis, is usually considered complicated. And you can also have non-obstructive pyelonephritis, and it's usually you could have a not very sick patient in the outpatient, or very sick patient in the hospital with perhaps sepsis and bacteremia. It is characterized by just mainly CV tenderness, as you know, almost always with fever and nausea and vomiting. Of course, remember, some patients are on steroids and they may not have fever. So what is the optimal empiric treatment for uncomplicated cystitis? Three days? 7 days? 5 days? What's your vote?
3 days.
Usually 3 days. 3 to 5 days, depending on the situation. What the guidelines recommend: first line, nitrofurantoin for 5 days. That is almost as good as 3 days of Bactrim. Why nitrofurantoin? Why nitrofurantoin is the first line? Because the absorption through the GI tract, or not the absorption, but the action of these antimicrobial to change your gut flora is minimal. So the chances of your flora to mutate they're minimal. And also because there is less chances of the bacteria eventually to become resistant, and has minimal side effects. Bactrim is good, but Bactrim may affect your gut flora. Quinolones, forget it. They affect your gut flora, they give you C. diff, etc. So nitrofurantoin is the first line. Bactrim for 3 days is the second line, depending on what's going on in your community. If the resistance is less than 20% in your hospital or in your community, then it's okay. But some centers have increasing resistance. Fosfomycin, one single dose, is also an option, and it's very nice. It's just one option, and just once a day, and also doesn't affect much your gut flora. So nitrofurantoin and fosfomycin, that's the good thing about these two. They don't really affect and the chances for the bacteria to become resistant are not as high. For quinolones, you can do quinolone for 3 days for uncomplicated cystitis. Again, the problem is that some centers are reporting increasing resistance. Here at Moffitt, the resistance is pretty high. So that's why it's like almost the last option. And also because it can change your gut flora, patients can have C. diff, etc. So it's an alternative for acute cystitis. What about amoxicillin, augmentin, and other oral beta-lactamics for uncomplicated cystitis? They are okay, but the problem is that resistance from E. coli and Klebsiella is pretty high, so that's why it's not really recommended. The absorption of some of them, for example, cefdinir, compared to nitrofurantoin is less. At least the concentration in the genitourinary tract is less. That's why they're really like not first line. Now, if you have an E. coli in the urine that's susceptible, it's okay if you cannot use nitrofurantoin or Septra. But they're not, of course, ideally to be started empirically without knowing the cultures. And this is Cartagena in Colombia. The old city in Cartagena at night. It's very nice. Now, what is the treatment for acute pyelonephritis? Now we discussed cystitis. Now we're moving to pyelonephritis. Can you do empiric treatment with quinolones? Yes, you can if your susceptibilities in the community to quinolones are less than 10%. And if you have a stable patient that can wait, like let's say it's an outpatient, it's not throwing up a lot, it's tolerating PO medication, then you could do that. And 7 days, interesting, is acceptable, not 14 days. But again, if it's uncomplicated pyelonephritis, if it's a healthy person with a bacteria that is susceptible and is outpatient, then you can do 7 days. For beta-lactamics for uncomplicated pyelonephritis, where you can do 7 days or 14 days, or with medications even like Septra, it's not clear. There is no enough studies. Probably a patient will do okay, but because we don't have data, then it's recommended to do 7 to 14 days on the rest of the antibiotics for pyelonephritis. But only for quinolones, 7 days is okay for uncomplicated pyelo. Again, if the patient is stable, that you're not going to admit to the hospital, but she, let's say, is one of the females here that's healthy, you can give her one dose of ceftriaxone pending the urine culture and send her on oral Cipro to finish, and then complete that if the bacteria is susceptible. If the resistance in the community is greater than 10%. Or just start her on ceftriaxone and then, of course, obviously de-escalate. Now, you can also use Bactrim for 14 days if the bacteria is shown to be susceptible. Now, if you don't know what bacteria you're dealing with and you have somebody with pyelonephritis, the best way to go in reality then will be ceftriaxone until you have the data, and then you can de-escalate. The same is true if the patient is admitted in the hospital very sick with a possible bacteremia. Ceftriaxone may be a good option. Now, if the patient is in the hospital at the VA with folate catheter for a long time, heavily treated with antibiotics, and is having pyelonephritis, then remember that Pseudomonas could be the cause, and then ceftriaxone will not be good. Again, patients who are hospitalized or required to be admitted to the hospital need IV antibiotics because of the concern that they may be bacteremic. This is basically a summary of what we say in the upper part, which is there is few words about asymptomatic bacteriuria, and then when is recommended to screen for asymptomatic bacteria, when it's not, and what are the drugs of choice for cystitis. Again, number 1, nitrofurantoin, then Bactrim, and then fosfomycin is not listed there, but it's a good option too. Then Cipro and beta-lactamides are at the bottom. And this is another summary of how to treat uncomplicated pyelonephritis versus on the right side, basically hospitalized patient is not considered uncomplicated pyelonephritis, but complicated. So complicated pyelonephritis, it will be a patient who is in the hospital, who has stents, who has cancer or obstruction, then that's complicated pyelonephritis, and you need 14 days of antibiotics. At the bottom, you see our susceptibilities from Moffitt, from the gram-negatives to different antibiotics. Cipro, really, the resistance from E. coli, Klebsiella, and Proteus, look at the E. coli. The susceptibility to Cipro is only like 50%, so that's pretty bad. You don't want to do Cipro for a UTI in Moffitt. Ceftriaxone is still good, except when you have Pseudomonas, and cefepime is very good. So depending on where you go, you will pick up the antibiotic. This is Cartagena, and I had to go a little bit fast because we were running off time. And so if you have any questions, you can Google it. I'm just kidding. Any questions? No?
If I may make a comment, I like how these guidelines again discuss the topic of collateral damage. The idea that when you as a physician prescribe an antibiotic, you want to think about not just what's going to be susceptible for the patient, what's going to treat the patient, but also the effect of your prescribing on the hospital's flora and on the flora of the community.
And in the environment, so Dr. Eller was mentioning that how these guidelines address the importance of prescribing the antibiotic not just to treat the bacteria, especially, but also they take in account the damage that the antibiotics can cause to the patient's flora and the environment. So that's really good. Okay? No problem.